very much, John. I'm one of John's colleagues and one of the local nephrologists working here at UCL on the Royal Free Campus, as you can see. And the task I was given was to explain how SGLT2 inhibitors benefit the kidney. And that was a task that I found a little bit harder than I'd expected, so bear with me. There are my relevant disclosures. So we now have 3 cardiovascular outcome trials that have reported kidney endpoints. And as you'll see from this slide, they've reported quite a wide variety of kidney endpoints. We don't have a renal MACE. I guess that would be a MAKE or a MARE, but we don't have one. And so what's happened in these trials is that various different endpoints have been reported. Now, what nephrologists want to know is that patients don't end up on dialysis machines or don't end up dying because they have end-stage kidney disease that hasn't been treated with dialysis or transplantation. So the harder endpoints here are the reaching end-stage kidney disease and starting on dialysis machines. But there are some softer clinical endpoints included in some of these trials, particularly the new onset of macroalbuminuria, progression of albuminuria, changes in GFR. But as I say, what we really want to see is initiation of renal replacement therapy or reaching end-stage kidney disease. Whatever these trials have reported, the news has been good, and we've already heard today that we're seeing substantial reductions in these composites that have been used in the different trials. So in EMPA-REG, this was driven largely by reductions in the progression of albuminuria, but in the CANVAS and DECLARE studies, we've seen a composite including some slightly more robust kidney endpoints. And the message is good and is exciting for nephrologists. And many of us did not expect these data to come out of these cardiovascular outcome trials. And we saw this meta-analysis this morning. Here's the renal component of the meta-analysis, showing that across the trials, there's homogeneity in terms of the effect, and that the renal effect is present, as we heard, whether or not the patient has prior overt cardiovascular disease. And this is the composite of renal worsening, end-stage renal disease or renal death. Not entirely clear how we define this, but I think it's a composite of changes in albuminuria and changes in GFR. Now, we should remember something. We should remember that these trials didn't include patients with more advanced chronic kidney disease, and this has been mentioned already today, but there were GFR exclusions in these trials, or these are probably what I should say are inclusions. So for EMPA-REG and CANVAS, patients needed to have a GFR of greater than 30 mils per minute corrected for body surface area to get into the studies, and with DECLARE, as we heard earlier, a creatinine clearance calculated using a different formula of greater than 60. And these are the percentages of patients with chronic kidney disease at baseline who were recruited into these studies. And they're reasonable percentages of patients with baseline CKD, particularly in EMPA-REG and CANVAS. What's CKD? Well, this is our two-dimensional classification system for chronic kidney disease, in which we define both the GFR and the level of albuminuria as albumin to creatinine ratio in a spot urine sample. And to have chronic kidney disease, by definition, you either need a GFR less than 60, or you need to have a GFR of over 60 with another marker of kidney damage. And albuminuria is a perfectly adequate and appropriate marker of kidney damage. So everything in green is normal, and the yellow to red gradation here shows increased risk of declining kidney function. So these are the patients that nephrologists see by and large in their clinics at the bottom. And the cardiovascular outcome trials, by and large, have included patients in these categories at the top with stage 3A disease or better. So by and large, the trials haven't recruited the patients that nephrologists are looking after. And of course, that's reflected, or that reflects the license for these drugs, as we heard in a previous talk. So let's move on to the topic I'm meant to be addressing, which is how do these drugs protect the kidney? And I think we can see from all these potential mechanisms here that we're not entirely sure is the honest answer, but there are several mechanisms and pathways that have been proposed. So perhaps these drugs improve the risk factors for progression of kidney disease, controlling the blood pressure, helping the patient to lose weight, improving the glycemic control. Perhaps by switching off an energy-hungry transporter in the proximal tubule, these drugs protect against renal hypoxia and improve renal oxygenation. There are experimental data to suggest that these drugs reduce inflammation, and that may be good in a patient with progressive kidney disease. But what I'm going to focus on today are the hemodynamic changes that have been associated with these drugs. And we're going to talk about the glomerular filtration and hemodynamic changes. The clue is in the GFR plots. And this is from EMPA-REG. This is placebo in black, empagliflozin, 2 doses combined in red over the duration of the trial. And we see here in the early stages an acute drop in eGFR in patients receiving empagliflozin of around about 3 to 4 mils per minute, followed by stabilization of eGFR throughout the study. But in the placebo group, we see a steady decline in eGFR over the study period. So these drugs are doing something acutely to kidney function. Here it is again. This is one of the phase 3 studies of canagliflozin, 1,450 patients, type 2 diabetes on metformin, Cana 100 or 300 in the 2 different colors, light blue 100, dark purple 300 against glimepiride as a comparator. And here it is, that acute drop in eGFR in the canagliflozin-treated patients, the progressive decline in kidney function in the glimepiride-treated patients. So this seems to be real. Okay, so what can change kidney function acutely? Let's go back to the glomerulus. Here is the glomerulus. Here is the afferent inflow arteriole, and here is the efferent outflow arteriole. And this section here, which is where the filtration happens, I was taught was a capillary tuft, but it's not a capillary because it joins an arteriole and arteriole, so it must be an arteriole. So it is a highly specialized arteriole with a leaky wall and an incomplete endothelial lining. But it's here that the filtration takes place. This is what determines the glomerular filtration rate. Now, there's a control mechanism that I'm sure I was meant to learn about in physiology but forgot all about. Here is the distal tubule that is derived from this glomerulus. So this is a continuation of this tubule down the loop of Henle, up again, and here is the distal tubule, which wraps back and contacts its own glomerulus. And at that point of contact, there is a specialized area called the juxtaglomerular apparatus, or JGA, where the epithelial cells of the tubule are specialized and are able to talk to the vascular smooth muscle cells of the afferent arteriole. So the glomerular effluent, if you like, the filtrate, can control the tone of the afferent arteriole. And that's how we believe we can change glomerular filtration in an acute setting. So to increase filtration, we'd want to dilate the afferent arteriole. That would increase the blood coming in. If we then constricted the efferent arteriole, we would increase the pressure in the glomerulus. That would increase the GFR. There's a higher pressure, there's more filtering going on, and that would enhance the amount of albumin that's passed out in the urine. Conversely, if we wanted to decrease filtration, we would constrict the afferent arteriole. We would dilate the efferent arteriole. This would reduce the intraglomerular pressure, reduce the amount of albumin coming out in the urine, and reduce the GFR. We're going to come back to the juxtaglomerular apparatus in just a minute. This is the clinical course, or the classic clinical course of diabetic nephropathy. And in the early phases here, you'll see there's what we call a hyperfiltration phase, where GFR actually increases. And we believe this is because the kidney is recruiting its functional reserve. There is increased filtration in all the surviving glomeruli, and as a result of this, GFR is increased. This is nephron mass at the bottom, and you can see that during this phase, we begin to lose nephrons. We also develop albuminuria. And as the disease advances and as we lose nephrons, we lose this hyperfiltration. We go back to the GFR that we started with, but then dip below. And here is the progressive decline in glomerular filtration rate. There is a point where there are insufficient surviving nephrons to leak albumin, and so at some stage, patients also lose their albuminuria. And this is where the nephrologist gets involved. It's apparent from clinical studies that we can improve this hyperfiltration by improving HbA1c. So we're now going to talk about juxtaglomerular feedback. Here is the juxtaglomerular apparatus, the distal tubule touching back to the glomerulus. This is the normal situation where the glomerulus is filtering a little bit of glucose and quite a bit of sodium. We have normal SGLT2 receptor activity. All of the glucose and some of the sodium is being taken up, but there is still sodium delivery to the distal nephron and therefore to the juxtaglomerular apparatus. Here we go. Here's the distal tubular lumen. Here are the macula densa cells, these specialized cells at this point of contact. Sodium is taken up by these cells, and through breakdown of ATP to AMP and release of adenosine, there is feedback to maintain vascular tone in the afferent arteriole. So here the adenosine binding to a receptor here on the mesangial cell, but the vascular smooth muscle cells and mesangial cells here are closely aligned, and this maintains through a tonic effect a tone, a normal tone in the afferent arteriole. Okay, what happens in diabetes? Here, the SGLT2 inhibitor is upregulated. There is an increased absorption of glucose, and with that, an increased absorption of sodium. There is a reduction in the delivery of sodium there is a reduction in the delivery of sodium to the distal tubule and the macula densa apparatus. No sodium here. This feedback system is shut down, and the afferent arteriole here dilates. And that's thought to be the mechanism underpinning the hyperfiltration, is that we've lost tubular glomerular feedback because sodium is being absorbed in the distal tubule along with glucose. So what can we do with SGLT2 inhibitors? Well, we can block the glucose and the sodium uptake. We can enhance or restore the delivery of sodium to the maxilla densa. We can switch back on the tubular glomerular feedback process, and we can constrict the afferent arteriole, and we can reduce the hyperfiltration, and we can reduce the intraglomerular pressure. Now, there's been a theory in nephrology going around many years, and you can see that from the rather ragged appearance of the headline at the top here. This is 1996, Kidney International. And this theory is that hyperfiltration, although it's an adaptive process, in the long term is harmful. And I put the key headlines here that if hyperfiltration persists, the hyperfiltering glomeruli eventually fail. It's like working overtime all your life. You're going to give out early because of the extra work. The pressure in the glomerulus is high. You're excreting, or you're filtering rather, and excreting a large amount of albumin, which gets taken up in the tubule. This is probably bad for the kidney in the long term. And the theory underpinning the ACE inhibitors and ARBs were that these reduced hyperfiltration, and that through reducing hyperfiltration, ACEs and ARBs were renoprotective. So that's the Brenner hypothesis. Let's just mention ACEs and ARBs because I think they're a useful analogy here. This is the glomerulus afferent arteriole. The efferent arteriole is constricted by angiotensin II. ACEs and ARBs inhibit the constrictor effect of angiotensin II on the efferent arteriole and therefore dilate the efferent arteriole. So they reduce intraglomerular pressure. And in fact, the last class of drugs that proved to be renoprotective were the ARBs in the setting of type 2 diabetes. And this is a study called RENAL from 2001, so almost 20 years ago now. 1,500 type 2 diabetics on standard treatment, randomized to losartan or placebo. These are reasonably hard clinical endpoints, doubling of serum creatinine, end-stage renal disease, or the combination of ESRD or death, and 20 to 28% reductions in these clinical endpoints, favoring the angiotensin receptor blocker over the placebo, with minor differences in blood pressure. And it was thought that ARBs had this specific renoprotective effect through efferent arteriolar vasodilatation. Now, ACEs and ARBs also acutely drop your GFR. And in fact, everything that has been proven to be renoprotective to date, low-protein diets, blood pressure-lowering agents, ACEs and ARBs, drop eGFR in the short term. So whilst it may be scary to put your patient on a new drug and find that the eGFR goes down and not up, this is probably a manifestation of the drop in intraglomerular pressure, which is in the long term protective for the patient. So here's an illustration from RENAL, from some of the patients in the RENAL study. This shows the long-term GFR slope, and this, by the way, is per year. And this is the tertile of the initial fall in eGFR. So these patients went up a bit, these went down more. You'll see that the greater the initial drop in eGFR, the slower the long-term GFR slope decline over time. So greater initial drop, greater renoprotection. Does this apply to SGLT2s? We don't know yet. So theoretically, here's the patient on the ACE or ARB. We can add in the SGLT2 inhibitor to the ACE or ARB and get additional renoprotection because the SGLT2 action is on the efferent arteriole, the inflow tract to the glomerulus. The RAS blockade effect is to dilate the efferent arteriole leaving the glomerulus. And you can see here that both these actions, constriction here, dilation here, reduce intraglomerular pressure, reduce albuminuria, and protects the glomerulus potentially in the longer term. Okay, now you'll notice that I've been talking about sodium and sodium delivery and not about glucose and glucose delivery. And that's because in the kidney world, we've found a disconnect between the HbA1c lowering effects of the SGLT2s and some of the clinical benefits. So these are from phase 3 studies of dapagliflozin and empagliflozin. You're looking here at HbA1c reduction stratified by GFR, greater than 90, 60 to 90, and 30 to 60. And you'll see here that the effect on HbA1c is attenuated at the lower levels of eGFR. So the more severely impaired the kidney function, the less likely these drugs were to reduce HbA1c. But if we look at body weight and if we look at systolic blood pressure, homogeneity in terms of the effect. So there's a disconnect here between HbA1c lowering and other clinical benefits of these drugs at low eGFRs. And we've also seen this in Canvas, and this was presented at the American Kidney Meeting just a few weeks ago. This is an analysis of the Canvas data, stratifying patients by the baseline eGFR, so normal greater than 90 in the green, less than 45 in the red. And you'll see here again a lesser reduction in HbA1c in the patients with the more severely impaired kidney function at entry into the trial, but yet pretty similar effects on blood pressure, body weight reductions, and reductions in urinary albumin creatinine ratio. So again, with the Canvas study, a disconnect between the HbA1c lowering effect and these other clinical effects. Now that really is the basis for taking these drugs outside non-diabetic kidney disease. And we've heard about this already earlier today, but hyperfiltration is on the causative pathway, we believe, of many chronic kidney diseases. So here's a patient with a normal EGFR who gets IgA nephropathy, or maybe they're obese, or maybe they get a disease called focal segmental glomerulosclerosis. They take a kidney hit, their remaining nephrons then hyperfilter, the pressure in those nephrons increases, there is further kidney damage through hyperfiltration injury, and GFR eventually declines, and proteinuria develops. And the theory is that if these drugs do attenuate this hyperfiltration, if SGLT2 inhibitors do attenuate hyperfiltration, then they may be useful in some of these non-diabetic kidney disease patients. And indeed, one of the ongoing trials which we've heard about already today, the dapagliflozin in CKD patients, has recruited patients with GFRs between 25 and 75. So we're pushing down a little bit lower into chronic kidney disease. But patients needed to have good going albuminuria. And you'll remember from my two-dimensional classification system at the beginning that patients with albuminuria are at higher risk of progression. These patients had to be on stable ACEs or ARB doses, or at least on optimized ACEs or ARB doses, because this is now standard of care in this population. And we recruited patients both with and without type 2 diabetes. The primary endpoints, again, are kidney composites with a cardiovascular component. The intervention is DAPA or placebo, and this is an event-driven trial that is ongoing. But the first study, as we heard, that we're going to hear about is CREDENCE. And you saw the headline CREDENCE trial stopped early due to efficacy. How is CREDENCE different from the other trials? Well, all the patients recruited into CREDENCE had chronic kidney disease by definition. So these patients had either a GFR over 60 with good going albuminuria, or a GFR less than 60 but greater than 30. So the lower GFR limit isn't a lot different from Canvas, but all the patients going in had chronic kidney disease. The HbA1c ranges were similar. ACEs and ARBs were mandated in CREDENCE because these patients, according to international guidelines, should be on HbA1cs, and there was no requirement for a prior cardiovascular history, although these patients are at high risk of adverse cardiovascular outcomes. So I'm going to finish there. Thank you very much. This is just a summary of, I think, where we are. I think there's little doubt that these drugs offer renoprotection, but remember that the populations we've studied so far have fairly mild chronic kidney disease, and we haven't focused on the advanced kidney disease endpoints of dialysis or death due to end-stage kidney disease. The most plausible mechanism of action is via this change in intraglomerular pressure, and I think we can see that in that acute hemodynamic change that occurs early on starting these drugs. Benefits logically are additive to those of RAS because we're looking at a different end of the glomerulus. The mechanisms seem to be independent, maybe a bit strong, but not entirely dependent on the level of HbA1c reduction. Whether we're going to go further into chronic kidney disease to lower EGFRs, I think is subject to debate at present. But if this really isn't about HbA1c lowering, we may be able to go into stage 3B and 4 patients with GFRs down to 20 perhaps. And as I've mentioned, there are ongoing studies in both patients with chronic kidney disease, both with and without diabetes. Thank you for listening.
Thank you very much, David. Any questions for Professor Wheeler? I see a few hands flying up over here. Charlie Thompson first.
David, thank you. I'm over here. I gave you advance warning of this question, but we know that hyperfiltration is the mechanism in some people with diabetes, and we think we know the mechanism, that it's the mechanism in people with obesity. We don't actually know that there's hyperfiltration in most forms of glomerular disease, and we don't know that there's hyperfiltration in the great majority of people with CKD and proteinuria in the general population. Are there some people in which switching off the blood supply to the glomerulus, the inflow end, and opening the tap at the outflow end might be actually bad for them?
Yeah, so that's a great question. And that feeds into what should we tell our colleagues when we see these big drops in EGFR. You know, if we're seeing a 30% drop in EGFR, is that a sign that we're overdoing things? And we do see patients who do drop their GFR quite a long way, certainly in the studies. Yeah, I mean, hyperfiltration, you know, as you know, is a popular hypothesis that has not been proven in man. There's reasonable data in animal models to suggest that the phenomenon occurs. But I'm sure it's not the pathway for progressive kidney disease, and I don't see it. I don't see it in clinic because none of the diabetics who come to me are at that stage of their disease. And I don't think a lot of the patients go through that phase as their disease advances. But yeah, good point, and this may not be the answer for all patients, agree.
David, just to follow on to that quickly, we see when we put patients on RAS inhibitors, we see a lot of variability in the drop of GFR. Yeah. Sometimes it gets a bit scary, and there's 20%, 30% acceptable or not, etc. How big is the variation you see with the SGLT2 inhibitors? Because it all looks very neat and tidy from those graphs, but those, of course, are means of big numbers.
Yeah, so I mean, so my experience of that is from problems that have occurred in the trials and patients who, you know, people have been worried about. Let me just say that we do see substantial reductions, and remember that in the ARBs, some patients went up, but those patients that went down had greater long-term renoprotection.
Yes, I guess the practical question there is how big a drop might one deem to be acceptable here, if there is indeed quite a lot of variation as there is with the RAS inhibitors?
So with ACEs and ARBs, I think we said 30% makes you worry about renal artery stenosis. And I think in primary care, when captopril first came out, we got a repeat GFR at 7 to 10 days. And if that was 30% lower, we said stop the drug. That's what I remember doing. Yeah. And maybe we should be doing the same.
This should be less susceptible to renal artery stenosis influence, though, from the mechanism.
Because it's
for obvious reasons, Right, I was hogging the microphone here. Magdi Yacoub.
Hi, David. Just to take my next-door neighbor's question a bit further and challenge you, that when there is a hypothesis, we should accept that we don't know. Yeah. I would say that there's even more logical explanation, and all the studies have shown that there is a systemic drop of blood pressure. Yeah. And that transmitted blood pressure into the glomerulus would be lower. Yep. And that would be, in my opinion, would be the plausible explanation. And that also explains that the current 50% of the type 2 with CKD don't have proteinuria. So that's the landscape of that, what you showed earlier of hyperfiltration has changed with the modern medications. So I still think that most of the benefit, and if you look at it, the blood pressure drops very quickly. And I would say, and when you say and do a parallel, which you showed the renal study very nicely, that was against a placebo. Still, there was a 3 millimeter of blood pressure drop in losartan. That 3 to 4 millimeter is good enough, at least in experimental setting, which I do, by micropuncture technique to lower the glomerular pressure. So I think Brenner hypothesis was good, but it doesn't exist in humans. That is my viewpoint.
Absolutely, Meg. There's still people arguing that that renal study result was due to a difference in blood pressure. But if I stood up today and just said they work by reducing blood pressure, that wouldn't have made, I wouldn't have been standing up for very long, and it would have been a much easier talk than the one I gave. And I think, you know, people want a hypothesis, and I think that is the most plausible hypothesis. It's not perfect, and there's lots of faults in it. I absolutely agree. And you two, of course, have picked out the faults before me. So thank you.
So we're still lacking the right positive controls in these studies, aren't we?
Absolutely.
Actually, because the blood pressure is the uncontrolled variable here. Bruce Hendry.
Thanks very much indeed. We heard earlier today about the upregulation of SGLT1 in the presence of these inhibitors. Would that upregulation in the context of renal endpoints be good, like a safety factor, or could it be reducing efficacy? And is there any hint from the studies we have that it's good or bad to inhibit both transporters?
So I think, I mean, some of these drugs do overspill onto SGLT1. And I think particularly there's a thought that canagliflozin has more SGLT1 activity and may act in places other than the kidney. But I don't think we know whether I think the question, Bruce, is whether inhibiting other SGLTs is of potential benefit. So if we inhibit SGLT2s, is SGLT1 upregulated in the kidney to take over? It's certainly upregulated in the context of diabetes. So the SGLT1 is upregulated as well as the SGLT2. And I think we know that by studying epithelial cells that come out in the urine and staining them for the receptors. And both SGLT1 and SGLT2 are upregulated. Remember, the SGLT1 is a very specific, low-intensity, high-specificity receptor. So it's not got a lot of capacity to take up glucose, presumably unless massively upregulated. It's the SGLT2 that does most of the glucose reabsorption, but the affinity for glucose is lower than with the SGLT1.
David, Derek wants a question.
Yeah. I just want to follow on from Dr. Thompson and Professor Yacoub, because I'm not a nephrologist, but you explain things very clearly. I just need to hear it about 3 more times, and I think I might understand it fully. But it's very interesting. But my question is, are you suggesting that ARBs and SGLT2 inhibitors independently, looking at changing the glomerular pressure differently at different sites, would both be renoprotective?
Yes.
Therefore, they can be used together.
Yes, absolutely.
Do you see a further benefit in that sense, or is it just because you're attacking 2 mechanisms, you're getting it?
Well, I think patients have gone into the existing cardiovascular outcome trials on ACEs and ARBs, and there's no suggestion that those patients on ACEs and ARBs got a lesser benefit from the SGLT2 inhibitor. We're now doing a trial where everybody's on an ACE and an ARB that has been stopped early because of efficacy. So we don't believe that putting these patients on ACEs and ARBs is going to negate the benefit of the SGLT2. And mechanistically, because they're affecting different parts of the glomerulus, there is a logic in adding one to the other to get added renoprotection.
I do understand. Thank you.
David, I just got one more question quickly, and that is that we've heard a lot about cardiovascular endpoints, and now you're talking about renal endpoints. Do you think cardiovascular death in the context of progressive CKD should be a different kind of sort of composite renal cardiovascular endpoint? Because we know the powerful association between dropping GFR and cardiovascular outcomes, and these drugs are meant to slow down the fall in GFR, and therefore an effect on the cardiovascular outcomes could conceivably be secondary.
Yeah, no, that's a great point. So we know that as GFR declines and as albuminuria increases, the risk of cardiovascular disease increases. And the green to red in my first diagram, I said represented risk of progressive kidney disease, but it could have represented risk of cardiovascular event. So yes, I think there is a possibility that the cardioprotection is a result of the renoprotection of the drug. But of course, the cardioprotection is about left ventricular failure, which is very much a kidney type, which is wrapped up with kidney function. And I've seen a renocentric view on how these drugs are cardioprotective. So, you're letting the water out. Sorry, you're letting the fluid out. You're letting the salt out. And in doing that, in opening the tap, you're reducing the intravascular volume and therefore protecting the heart. from progressive damage. But yeah, I mean, I think why do the endpoints include kidney and cardiovascular? I think largely because the cardiovascular endpoints are difficult to separate out and are an important outcome for a kidney patient.
Okay, well, thank you very much, David.